Picture the 67-year-old grandmother, stage 4, ER/PR positive, and HER2 negative breast cancer. Bone metastases everywhere in her skeleton and tuned for the battlefield. First round of standard chemotherapy was brutal. Nausea that kept her bedbound, her hair gone, neuropathy with every step on fire. Mouth sores so raw you couldn't eat. Fatigue that stole her grandchildren's laughter. She vowed never again. Then the news story came in. She saw a survivor from Envita Medical Centers who had fought back with precision oncology. So she dove in. Not a miracle, a blueprint. Hi, I'm Dr. Dino Prato, founder of Envita Medical Centers. And for the last 25 years, my team and I have helped thousands of patients who have failed the standard chemotherapy in standard hospitals across the country and integrative care. And today I'm going to share with you a real story because we need to put precision to the test. And we're going to do that in this episode on this breast cancer case. And the key is going to be about understanding blueprints to breast cancer. And we're going to go through this patient story, which we have many of them. And I just selected one because I think it's important to share these stories so patients like you or your family members can understand how important precision oncology is. So we're going to talk about mapping the tumor, how we microdosed it, and we used interventional radiology oncology to elevate care and immune targeting. And then 14 weeks later, the bones healed, the pain was gone, her life reignited with energy, and this patient had a good response. And so everybody's different, but I just want to go over these cases because the majority of patients that come to us, we're able to help them greatly. So here's where we're going to get going with this case. So she didn't just start as a rebel. She started out, as most patients do, just following the standard rules of oncology. You're diagnosed, you get sent into treatment. Her case was an invasive ductal carcinoma. So it had an estrogen positive, progesterone positive, and a Herceptin negative. Now, why is this important? Because when you're HER2 negative, you don't have the Herceptin drug that can slow things down. It doesn't cure the cancer, it slows things down. So now you have to be particularly more detailed with care, especially if the hormone blockades didn't work very well. So she took conventional chemo and she had a lot of suffering. So when it reoccurred and it went into her bones, she said, I'm not doing any more of this poison. What she wanted was a shortcut, or at least something better. She wanted something smarter. But she was out of hope until she saw a story of one of our patients, which happens often, and then contacted us and we began this work, which I'm going to go into here in a minute. She wanted something smarter. She didn't want to carpet bomb the tumor, but she wanted guided care, which makes sense. I believe that's something everybody deserves. It was diffuse and it had spread to the bone. Severe toxicity to the prior chemotherapy means we got drug resistance to overcome. It's not going to be simple. We did the deep mapping, DNA, so we weren't just looking at a few hundred DNA, all the full next generation sequence DNA, which you usually don't get. Full transcriptomics, which is really run by nobody. Thousands of markers, immune spatial biology only seen in research pharmaceuticals. We ran these on her and the deep mapping guided us. So precision starts with these types of maps. And why we run these maps is so that we can see where the mutations are, what the best drug matches are, and where we have to custom go build the treatments when there isn't a match. So we ran the RNA transcriptomics to see which pathways we're actually on. Was it estrogen signaling, cell cycle arrest, resistance routes, multi-drug resistance? And so we ran immune spatial biology in high resolution to look at the tumor microenvironment around the tumors. And we could see where the immune system was sitting. And they couldn't enter. There were stromal barriers around the tumor and scars, and there was no way of the immune system getting there, not to mention any of the IV chemotherapy that she was given. So the maps told us there was a lot of things wrong with this case and we needed to target it. So we geared in our treatment. The stromal barriers are interesting. It's like a fortress. If you want to see my video on this, it's called the Great Wall of Cancer. A lot of cancers and late-stage cancers can develop these fibrous walls, making chemo very difficult to get to. That's why sometimes we use image-guided surgery, minimally invasive, to go in with a catheter the size of a whisker or a hair to go right into the tumor, snake it right into the belly of the tumor, kill it, and seal the blood supply. This is really important because it shuts down the growth of the cancer and begins the immune system to recognize the roadblocks and start using your body's own natural ability to heal those roadblocks of the immune system. So there's multiple pathways going on here. And it's important that you see that step one, after we did all the testing, we started looking at what was the most gentle but effective way for her to be treated with chemotherapy. So we use this genetically targeted fractionated chemotherapies, microdosed, not just low dose, but it's targeted to the DNA, RNA, and immunity because everything we do is immune centric. So we released the damps, her immune system got activated, and this short burst of chemotherapy, she didn't lose her hair, she kept her energy, felt great, very different than her previous experience. But we also knew her pharmacogenomics. We knew what she could and could not metabolize, so we custom built it to that. Those pulses created damps, these danger signals which waked up the immune system, woke it up from its slumber to find the tumor and go after it. And then we starved the blood supply to the cancer and killed it. Then we added adjuvant support so that we could turn turn this cold tumor into hot, which means the immune system is going to go to work, because whenever you're dealing with liver metastases and bone, that's really, really important. And in her case, we used phytotherapeutics that were specifically targeted, designed by our pharmacies for intravenous delivery direct to tumor. Combine those with the right on-label and off-label drugs directly delivered to her body and to the tumor, and matched it to her map. This made all the difference. Based on her DNA, RNA signals, we layered in the treatment, we custom built it. We looked at the hormone pathway blockers, on off-label drugs, all the modulators, and the appropriate PIK3, AKT, mTOR, and all these different routes. We looked at the blockers, or on and off-label modulators, or phytotherapeutics, and the goal was a multi-pathway to shut this tumor down, not using a hammer, but precision. So we used adjuvants because we want to look at things that are what was causing her cancer and what was bringing the inflammation about in her cancer. So we wanted to treat it and cool it down. And so we went after the stromal barrier by going straight to the tumor, but then we went to the rest of the body by alerting the immune system where to find these circulating tumor cells that were already spreading, and we used interventional radiology, oncology to get to that tumor, and we used immunotherapy to get to the rest of the body so that it could find these micrometastatic cells, early baby cancer cells, and get rid of them. That's what your immune system does every day. Her results were fantastic. High local concentrations only where they needed it, no side effects, no loss of energy, loss of hair like she had in the past. In fact, she felt better and had more energy because we were restoring her body with IV nutrition all along the way with the right nutrients to restore her body and make sure the chemotherapy wasn't hurting her. Detoxing it from the liver, getting it out of her tissue. Because she already had nerve damage, we wanted to protect the nerves. So to finish the job, we brought in the key immune system, the natural killer cells and dendritic cells. These are the keys to fighting cancer. We got the T cells. We took her cells, grew them, expanded them, typed them specifically to her DAMPs and her peptides, and the rest is history. She responded very, very well, went into full remission, and the patient really did what she wanted to do, get the right treatment with precision and avoiding the side effects. So every couple of weeks, we continue to measure during the time she was under care, her circulating tumor cells, her methylation scores, and they were just improving. The timing of care worked well, she responded well, and the tumors were gone, and she's in full remission. So that's the key here to precision oncology. The results took about 14 weeks, and we look back at these stories that we see with patients. Some take less, some take more. It just depends on how their body heals. But when you give the body the right things that it needs, it can heal. And if you do the treatment on the targeted pathway, you give the body the advantage to restore the body's normal function and eliminate and eradicate the cancer. But this was a blueprint. This wasn't guesswork. This was precision. It isn't luck. And so we have to remember that when you have precision oncology, you just have such an advantage that most patients don't see. So if we look at the conventional versus the precision path, two different paths. The conventional path would have been a common for ER, PR positive, HER2 negative. Bone metastasis would have been systemic, full doses, and full cycles of chemotherapy that were highly toxic. But we have to remember she already had toxicity from her previous chemotherapy and neuropathy and damage, so this would have just been horrific. Endocrine therapy and CDK type agents would have been normal in standard chemotherapy, but based on our testing, she didn't tolerate these well. And then they would have done radiation in the bone as palliative care, not to eliminate it, but just to slow things down. And systemic delivery of the chemotherapy wouldn't have worked because she had stromal barriers. So imagine all this high-dose chemo causing further weakness to her organs and nervous system, but not being able to actually get to the tumor because she had a wall around her tumor blocking it. So this is why precision oncology was essential in this case, and in really many cases. The genetic targeted fractionated chemotherapy got us where we wanted. They were the right drug targets, but only 10% the normal dose, and just at the right time. So she never got weak, never lost her hair, kept her energy, but we got the tumors to die. But we did it by getting the immune system involved, not just letting the chemo do its work, getting the chemotherapy directly to the tumor with interventional radiology oncology. Cool the inflammation, sensitize and protect the liver with the immune system. That was the key. And we did that with the combinations. Then while we were there, we used chemoembolization to cut off the blood supply to the tumor and kill it. And then autologous adoptive immunotherapy to teach the immune system to fight the cancer and go after it. So it wasn't just about reducing chemotherapy, it's really rethinking the entire delivery and strategy with the right targeting. That's the difference. So how do you explain this to the average patient who may not know they need this now? Well, there's a lot you don't know when you're going through cancer, especially if you don't have the deep mapping and targeting and planning. You don't know, you won't have access to adjuvants, you won't have access to targeted off-label, you won't have access to on-label that's targeted because there was no testing done. That's the advantage of precision testing. You won't have direct-to-tumor interventional radiology oncology, which gets the chemotherapy right to the tumor. If you have a fibrous tumor and it's thick, you're not getting anything in there with chemotherapy. You have to go straight to tumor, and that's the difference. Otherwise, you won't be able to cut the fuel of the tumor out and stabilize the immune system at the region of the tumor. This is the difference. So 6 questions you need need to ask after we finishing this up that you could use when you're talking to your doctor. Will you run DNA, next generation full sequencing, RNA, full transcriptomics, and immune spatial biology to build a treatment map for me? And I'm going to tell you 99% of the time is no, because these are high-level laboratory tests we don't see anybody running at this level. It will come someday, but it's just not here yet. Not just a few DNA, RNA tests, I'm talking thousands. And then with that, can you custom build the treatment to me? Can you custom build the chemo, on, off-label, integrative adjuvants? Can you build them in your custom pharmacies and deliver them to me in a minimally invasive direct-to-tumor mechanism? And the answer will likely be no, but it's worth asking the question. And then are you going to use adjuvant supportive care, phytotherapeutics that are targeted for me that can help me fight my cancer and sensitize it to protect me? That's going to be a really big question, and most standard oncology will not be set up to do that. And some integrative doctors might use a few tools in that area, but it won't be targeted. So you want to ask, am I a candidate for interventional radiology oncology delivery of these custom-built drugs to the tumor? And how are you going to adapt and monitor my cancer? Are you just going to use tumor markers or imaging? Are you going to use circulating tumor cells, CT-free DNA, and methylation scores so we can see if the cancer is coming back way before it comes back? That's the difference. So this patient vowed that she didn't want chemotherapy anymore, but she wanted precision. But I argue that everybody needs precision, because then you can see what the best plan is for you, and then from there make the decisions you need to make to be well. I hope this was helpful, and may the Lord bless you on your journey to healing. And remember, don't be scared. Get more information, because precision targeting can help you. May the Lord bless you on your journey to healing.